Menorrhagia, also called hypermenorrhea, describes menstrual bleeding that is excessive in volume or duration. Clinically, it is defined as loss of greater than 80 milliliters of blood per cycle, or bleeding that requires changing a pad or tampon every hour, or persists longer than 7 days. The condition can be intermittent or chronic, and often leads to iron deficiency anemia, fatigue, and reduced quality of life. Women may describe the experience as a faucet that never turns off, because the blood loss feels relentless. Heavy bleeding may be unnoticed in adolescents who consider it normal, but it frequently results in missed school or work, frequent sanitary product changes, and an emotional burden stemming from the perception of an out-of-control body. The etiology of menorrhagia can be divided into hormonal, structural, systemic, and iatrogenic categories. Hormonal imbalance, excess estrogen without adequate progesterone, leads to prolonged proliferative phase, resulting in a thickened endometrium that sheds heavily. Example: anovulatory cycles in polycystic ovary syndrome, PCOS, or in perimenopause. Uterine fibroids, leiomyomas, benign smooth muscle tumors distort the uterine cavity and increase surface area of the endometrium, causing more vessels to bleed. Submucosal fibroids often produce the most pronounced bleeding. Endometrial polyps, localized overgrowths of endometrial tissue. Their friable stroma can bleed excessively, especially after intercourse. Thyroid or endocrine disorders. Hyperthyroidism accelerates metabolism and can increase bleeding, while hypothyroidism may cause menstrual irregularities that include heavy flow. Coagulation disorders, von Willebrand disease, platelet function defects, or low factor VIII levels impair clot formation. So once bleeding starts, it is hard to stop. Iatrogenic causes, certain intrauterine devices, especially copper IUDs, anticoagulant therapy warfarin, direct oral anticoagulants, and prolonged NSAID use can exacerbate bleeding. Other structural lesions, adenomyosis, endometrial tissue within the myometrium, and malignant lesions such as endometrial hyperplasia or cancer, though less common, can present with heavy bleeding. Think of the uterus as a garden, and over-fertilized soil, excess estrogen, and invasive weeds, fibroids, cause the garden to produce too many flowers' blood vessels that droop and bleed. Normal menstrual physiology involves cyclic proliferation of the endometrium under estrogen, followed by progesterone-mediated secretory changes, and then withdrawal-induced shedding. In menorrhagia, several pathophysiologic mechanisms converge. Endometrial hyperplasia. Prolonged estrogenic stimulation leads to a thickened, highly vascular endometrium. The increased surface area and fragile newly formed vessels bleed more readily. Impaired hemostasis. Defects in platelet adhesion, for example, von Willebrand factor deficiency, or in the coagulation cascade, reduce the formation of fibrin clots, allowing blood to continue oozing after the normal vasoconstrictive response. Increased prostaglandin production. Elevated uterine prostaglandin F2 alpha can cause vasodilation and inhibit platelet aggregation, further aggravating bleeding. Structural disruption. Fibroids, polyps, or adenomyotic islands physically disrupt the orderly vascular network, creating aberrant vessels that are prone to rupture. The resultant picture is comparable to a sponge that absorbs more fluid than it can expel. The endometrium soaks up blood, but the clotting squeeze is inadequate, leading to persistent loss. Menorrhagia affects roughly 10 to 20% of women of reproductive age worldwide, translating to millions of affected individuals each year. The condition most commonly emerges in late adolescence, 15 to 19 years, and peaks between the ages of 20 to 35 years, coinciding with the highest reproductive hormone activity. Prevalence rises again in perimenopausal women as anovulatory cycles become more frequent. Risk factors include family history of fibroids or bleeding disorders, Obesity, higher peripheral conversion of androgens to estrogen. Underlying endocrine disease, thyroid, PCOS. Use of anticoagulants or certain hormonal contraceptives. Because heavy bleeding is often normalized culturally, many women delay seeking care, resulting in a substantial gap between true prevalence and reported cases. Clinically, menorrhagia presents with both quantitative and qualitative features. Quantitative, need to replace a sanitary pad or tampon every hour, or use more than 6 pads in a 24-hour period. Menstrual blood clots may be larger than a quarter, approximately 1 centimeter, and often appear dark and gelatinous. Duration, bleeding that lasts longer than 7 consecutive days or cycles that occur at intervals shorter than 21 days. Anemia-related symptoms, fatigue, dyspnea on exertion, dizziness, pallor, tachycardia, and in severe cases, spoon-shaped nails or koilonychia or pica, craving non-food items. Anecdotally, women describe feeling like a car running on an almost empty fuel tank, unable to sustain normal activity. Psychosocial impact, embarrassment, anxiety about leaking, disruption of daily routine, and reduced sexual satisfaction. These signs should prompt a comprehensive assessment for underlying pathology and iron status. Diagnosis follows a systematic step-wise approach. 1. Menstrual diary. The patient records the number of pads or tampons used, timing of changes, clot size, and duration for at least 2 cycles. This quantitative data helps confirm greater than 80 milliliters loss. 2. Laboratory studies. Complete blood count, abbreviated CBC, to assess hemoglobin and hematocrit and mean corpuscular volume, abbreviated MCV serum ferritin and iron studies to gauge iron stores. Thyroid-stimulating hormone, abbreviated TSH, to rule out thyroid disease. Coagulation profile, abbreviated PT, INR, a PTT, and specific assays for von Willebrand factor when a bleeding disorder is suspected. 3. Physical pelvic exam. Checks for uterine size, cervical lesions, or palpable fibroids. 4. Transvaginal ultrasound. First-line imaging to identify fibroids, polyps, adenomyosis, or endometrial thickness greater than 5 millimeters in the proliferative phase. 5. Hysteroscopy, office or operative. Direct visualization and removal of intrauterine pathology when ultrasound is inconclusive or when polyps or fibroids are suspected. 6. Endometrial sampling, biopsy. If the patient is greater than 45 years old or has risk factors for endometrial hyperplasia or cancer. The process mirrors a home inspection. Start with the homeowner's description diary, then examine the structure exam, use imaging ultrasound, and finally peek inside with a camera hysteroscopy if needed. Menorrhagia is categorized based on etiology and temporal pattern. Primary menorrhagia, heavy bleeding without an identifiable pelvic pathology. The most frequent cause is anovulatory cycles, often due to hormonal imbalance, excess estrogen, insufficient progesterone. These cases respond well to hormonal therapy. Secondary menorrhagia, bleeding attributable to a structural or systemic disorder such as fibroids, polyps, adenomyosis, thyroid disease, or a coagulopathy. Diagnosis requires imaging or laboratory confirmation. Acute heavy bleeding, sudden onset of profuse flow, often precipitated by medication changes, infection, or a ruptured polyp. Chronic menorrhagia, persistent heavy flow over months to years, typical of fibroids or hormonal dysfunction. Understanding the classification guides therapeutic choices, from simple hormonal regulation for primary cases to targeted surgery for secondary lesions. Non-pharmacologic measures. Iron supplementation, oral ferrous sulfate 325 milligrams, 1 to 2 times daily, aiming for a rise in hemoglobin of 1 gram per deciliter over 4 to 6 weeks. Intravenous iron is reserved for intolerant patients or when rapid repletion is needed. Lifestyle: high iron diet, red meat, legumes, leafy greens, vitamin C to enhance absorption, and regular aerobic exercise to improve overall cardiovascular health. Pharmacologic options: NSAIDs, ibuprofen 400 to 600 milligrams every 6 to 8 hours inhibit prostaglandin synthesis, reducing menstrual blood loss by up to 30%. Tranexamic acid 1 gram by mouth every 6 hours for 4 to 5 days, antifibrinolytic that stabilizes clots. Useful for women who prefer non-hormonal therapy. Combined oral contraceptives provide cyclic estrogen progestin, suppressing endometrial proliferation. Typical dosing is 21 days on 7 days off. Levonorgestrel releasing intrauterine system, 52 milligrams, delivers 20 micrograms per day, locally reduces bleeding by up to 90% within 6 months. Especially effective for fibroid-related bleeding. Progestogen only options, for example, norethindrone acetate 5 milligrams daily, useful for women who cannot take estrogen. Surgical interventions: office hysteroscopic polypectomy or myomectomy, removal of submucosal polyps, fibroids with minimal anesthesia. Laparoscopic myomectomy for larger intramural fibroids, preserving uterine integrity. Endometrial ablation, thermal radiofrequency hydrothermal, destroys the functional endometrium, suitable for women who have completed childbearing. Hysterectomy, definitive cure for refractory cases, can be performed vaginally, laparoscopically, or abdominally, depending on uterine size and surgeon expertise. Decision-making follows a step ladder. Start with lifestyle iron, add NSAIDs, or tranexamic acid, progress to hormonal therapy, and reserve surgery for refractory or structural disease. While not all cases are preventable, risk reduction strategies are effective. Routine gynecologic screenings. Annual pelvic exams and ultrasounds every 2 to 3 years for women with known fibroids or a family history can catch lesions early. Early treatment of endocrine disorders. Screening for thyroid disease and managing PCOS with lifestyle or metformin reduces estrogen excess. Management of coagulation disorders. Prompt diagnosis of von Willebrand disease or platelet function abnormalities allows for prophylactic tranexamic acid during menses. Weight control and balanced diet. Maintaining body mass index less than 30 kilograms per square meter limits peripheral aromatization of androgens to estrogen, decreasing proliferative stimulus. Appropriate contraceptive counseling. Selecting hormonal methods that stabilize the endometrium, for example LNG-IUS, can preempt heavy bleeding in at-risk women. Avoidance of unnecessary anticoagulation. When anticoagulants are required, using the lowest effective dose and monitoring hemoglobin can mitigate bleeding complications. Just as a car benefits from regular oil changes, the reproductive system stays healthier with periodic professional evaluation and lifestyle care. The outlook for women with menorrhagia is generally favorable when the underlying cause is identified and treated promptly. 80 to 90% of patients achieve normal menstrual blood loss and normalization of hemoglobin levels within 3 to 6 months of appropriate therapy. Untreated heavy bleeding can progress to severe iron deficiency anemia, hemoglobin less than 8 grams per deciliter, which is associated with cardiac strain, diminished cognitive function, and decreased work productivity. Rarely, chronic anovulation may impair endometrial receptivity, potentially affecting fertility. However, most women regain normal ovulatory cycles after hormonal regulation or removal of structural lesions. Long-term complications such as uterine rupture are uncommon, and there is no evidence that menorrhagia alone increases the risk of malignancy. Overall, early diagnosis, tailored treatment, and patient education ensure a high quality of life prognosis. Levonorgestrel releasing intrauterine system, LNGIUS expansion. Large-scale trials, for example the SILCS study, demonstrated a 93% reduction in menstrual blood loss at 12 months, with high patient satisfaction and minimal systemic side effects. Hysteroscopic morcellation devices. New powered morcellators, for example MyoSure 2.0, shave submucosal fibroids and polyps in seconds, decreasing operative time by 40% and preserving uterine integrity. Genetic profiling. Genome-wide association studies, GWAS, have identified loci on chromosomes 1p36 and 7q21 linked to fibroid susceptibility, opening avenues for personalized risk assessment. Artificial intelligence, AI, ultrasound analysis. Deep learning algorithms trained on thousands of sonographic images can automatically quantify fibroid volume and detect subtle adenomyotic changes with greater than 90% accuracy, reducing inter-operator variability. Novel antifibrinolytics. Intranasal tranexamic acid formulations are under investigation for rapid onset and better tolerability, potentially offering an alternative for women who cannot swallow pills during heavy bleeding. Non-hormonal endometrial ablation. Radiofrequency-based balloon ablation, for example the balloon ablate system, provides a one-step, office-based procedure with a 75% long-term success rate, preserving fertility in selected cases.